Hello friends, today's topic is acute kidney injury and how to treat with acute complication of kidney injury. So first complication is fluid management. For patient with the renal dysfunction, fluid management is often crucial because of the decreased sodium and water excretion. The determination of the fluid management should be based on the thorough physical examination as well as evaluation of daily weights, vital signs, and net fluid balance. Daily weights are often best means of assessing the net balance between the intake and the output. Additional data may be provided by measurement of central venous pressure or ultrasound assessment of the intravascular volume. For patients with the pure prerenal azotemia attributable to hypovolemia, restoration of the normal volume status is usually sufficient to return blood urea nitrogen and creatinine to their normal levels. A normotensive volume depleted azotemic patient can receive up to 1 liter of saline during 4-hour period with the expectations that renal perfusion in the urine flow will improve rapidly. Volume depleted patient with hypotension should receive more aggressive fluid resuscitation at least until their blood pressure normalizes and signs of hypoperfusion resolve. The estimated isotonic fluid replacement should be based on clinical findings. With orthostasis, it may be estimated that patient is experiencing an uh, extracellular fluid deficit of at least 10%. Fluid replacement in these circumstances should be administered regardless of the patient's urine output and preemptive diagnosis of ATM, as recovery of renal function can be hastened by early adequate fluid repletion. Hypovolemia may complicate intrinsic renal disease and urinary tract obstruction, superimposing a low perfusion state on the azotemia caused by this condition. The finding of low fractional excretion of sodium in patients who previously had high FeNA might indicate that although tubular function has recovered and renal hypoperfusion persists. So fluid replacement should be given using isotonic solution. For euvolemic patient, the following formula can be applied to estimate daily fluid requirement. Daily fluid replacement, that is ml per day, urinary extrarenal insensible losses, where insensible losses are approximately 250 ml per day. For febrile patient, add 500 ml per day for every degree Fahrenheit more than 1 knot. For edematous patient requiring fluid removal, the rate of diuresis should be adjusted to avoid intravascular volume depletion, which could exacerbate the acute kidney injury. Diuresis is the mainstay of the management in patients with the volume overload and non-oliguric AKI. Diuretics are essential for maintenance of fluid balance in responsive patients. Loop diuretics are principal agent and are given by intravenous bolus or continuous infusion. Dose adjustment may be required to avoid decreased renal perfusion, which could impair renal recovery or ototoxicity with hearing loss and tinnitus. Concomitant use of other diuretic agents that act at different segment of the nephron may enhance the urine output. Patients with the diuretic resistant oliguria often require renal replacement therapy. Now, next is parenchymal renal disease. Although acute interstitial nephritis usually respond to discontinuation of culpable drug, the recovery may be protected. So the steroid should be considered for patients with drug-induced acute interstitial nephritis associated with significant reduction in GFR and for patients who do not promptly respond to withdrawal of offending agents. These patients often require renal biopsy to confirm the diagnosis. If steroids are used, the initial dose of prednisolone 1 mg per kg per day for 1 to 2 weeks, followed by slow taper over 1 to 3 months, depending on the response. Briefly, in patients with AKI associated with proteinuria, hematuria, the diagnosis of glomerular disease should be considered. A renal biopsy may be helpful not only to aid the diagnosis but also means of predicting response to therapy. Patient with the sudden loss of renal function associated with the nephritis may have rapidly progressive glomerular nephritis. So rapidly progressive glomerular nephritis is broken down into three categories. like pauci-immune glomerulonephritis, anti-glomerular basement membrane disease, that is good posture, immune complex mediated disease. The majority of these diseases require immunosuppressive therapy with steroids. That is high dose intravenous corticosteroid consisting of 250 1000 mg of methylprednisolone daily for 3 days. In combination with the steroid sparing agents like cyclophosphamide, myclophenolate, rituximab, and occasionally plasmapheresis. In anti-GBM disease, pulse steroid, oral cyclophosphamide, and plasmapheresis are combined for maximum effectiveness. Plasmapheresis is employed to clear plasma of formed antibodies, while immunosuppressive drugs prevent the formation of new pathogenic antibodies. Several different therapies have been proposed for the treatment of ATM. Dopamine at low doses dilates the interlobular arteries, afferent and efferent arterioles, resulting in increased renal blood flow. However, clinical trials have not supported the efficacy of low-dose dopamine infusion in the treatment of established ATN and is not recommended. Phenol is the selective dopamine 1 receptor antagonist that lacks other alpha and beta adrenergic effect and has also been proposed as the treatment for AKI. Now, the treatment of post-renal failure, timely relief of urinary obstruction is the goal of therapy for post-renal AKI. Acute intervention is mandatory in the presence of complete and bilateral urinary tract obstruction or severe metabolic and hemodynamic complications of AKI. Coexisting fever or any other evidence of urinary infection proximal to obstruction requires rapid decompression procedure to avoid bacteremic shock. When bladder outlet obstruction is suspected, insertion of bladder catheter should be attempted. If this is not possible and is occasionally the case in patient with prostatic enlargement or urethral stricture, urethral dilatation and percutaneous cystotomy should be performed. AKI due to upper urinary tract obstruction can be relieved by either retrograde insertion of urethral stent or by percutaneous placement under ultrasonographic, fluoroscopic, or CT guidance of nephrostomy tube into renal pelvis. Because of the defect in distal nephron function associated with high-grade obstruction, patient may develop hyperkalemia, hyperchloremic metabolic acidosis, and hyperlipidemia. Water and bicarbonate replacement are often required and can be administered as a solution of 5% glucose and water to which sodium and bicarbonate has been added. The patient's plasma volume and serum sodium should determine the tonicity of administered. If the patient is hypovolemic, the isotonic solution should be used. If the patient is hypernatremic, hypotonic solution is needed. Hyperkalemia may respond to development of post-operative diuresis as well as correction of acidosis. A dramatic post-obstructive diuresis often ensures acute relief of urinary obstruction. This usually reflects the mobilization of urine sequestrate within the dilated uretrovesical system as well as excess CSF solute retained during period of obstruction. As such, this postoperative diuresis is considered appropriate to pre-existing volume expansion. In some patients with correction of bilateral obstruction, large diuresis and natriuresis may ensure, which results in hypovolemia, sometimes frank shock. The mechanism of this inappropriate diuresis is poorly understood but may involve release of natriuretic substance. These patients require fluid replacement, usually hypotonic saline, to repair deficit and match urinary losses. The useful technique is to measure urinary sodium, potassium concentration periodically to determine composition of replacement fluid. However, it is essential to avoid excessive fluid replacement as this will simply prolong the diuresis. Abnormal drug metabolism. A complete survey of the patient medication should be made. Drugs such as NSAID-AC inhibitor that interfere with the renal blood flow, GFR autoregulation should be discontinued. When possible, aminoglycoside antibiotic and other nephrotoxic drugs should be replaced with non-nephrotoxic agent. Contrast procedure should be avoided so as not to compound renal dysfunction in patients with AKI or CKD. If this is not feasible, the risk should be minimized by taking prophylactic measures. In addition, the dosage of drugs dependent on renal metabolism and excretion should be adjusted appropriately. Some drugs, for example, aminoglycoside antibiotic and digoxin, are excreted almost entirely by the kidney. If the dose and dosing interval is unchanged, reduced renal function lead to accumulation of the drug in body fluids and eventual drug toxicity. Other agents are hepatically metabolized, but active metabolites are renally excreted. For example, benzodiazepine. Phenytoin, independently of its excretion, may reach toxic concentration because large proportion of the administered drug is displaced from albumin binding sites in the urine. Drug doses need to be altered in most instances to accumulate for residual renal function and the effect of dialysis on drug. Now, the nutritional therapy. Guidelines for nutritional therapy in AKI are similar to those in the other ICU patients. Patients with the AKI are often catabolic and increase their production of nitrogenous products that require excretion. The degree of catabolism reflects the level of patient's metabolic stress. Protein and caloric requirements are much higher for patients with catastrophic illness and multiple organ system failure than those with the mild and moderate. Although caloric replacement need to be adequate to reduce the tissue catabolism, prevent ketosis, and meet the patient's basal nutrition need, the clinician must avoid providing excess substrate for generation of metabolic-based product. This is particularly challenging for patients who are not yet being dialyzed. Once patients are on dialysis, they are allowed more liberal fluid intake and can receive greater intake of carbohydrate, protein, and fat, limited only by the rate of dialytic fluid and solute removal. Now, the next complication is hyperkalemia. Hyperkalemia is most immediately life-threatening electrolyte imbalance encountered in patients with renal disease. During AKI, hyperkalemia arises from the inability of the kidney to handle the excretory burden of the potassium. Sources of the potassium should be identified and regulated. Potassium load may be endogenous that can occur by tissue breakdown, hematoma reabsorption, or it could be exogenous. That is the diet, intravenous fluid, and medication. Even when GFR is substantially reduced, kidneys can excrete the large amount of potassium provided that tubular secretion is intact. For this reason, hyperkalemia more often occurs among patients with parenchymal and postrenal AKI. Urine flow rate is important determinant of tubular potassium secretion. Therefore, oliguric patients are more prone to potassium imbalance than the non-oliguric patient. Many commonly used medication, including heparin, NSAID, AC inhibitor, can also impair tubular potassium secretion. This should be discontinued for hyperkalemic patients. Now, the next complication is metabolic acidosis. The kidney's ability to excrete metabolically produced acid may be reduced, particularly in parenchymal and obstructive disease. Because acid excretion is primarily tubular function, the degree of acidosis may not always correlate with the degree of GFR impairment. Indeed, pure tubular acid excretion abnormalities may exist independently of azotemia. Metabolic acidosis that result from the failure of tubules to excrete hydrogen ion and conserve bicarbonate normally produce hyperchloremic and low anion gap acidosis. When GFR is severely impaired, retention of acid may produce high anion gap acidosis. Bicarbonate supplementation in the setting of metabolic acidosis remains controversial as there is no study demonstrating beneficial effect of this approach. In addition, bicarbonate supplementation may cause volume overload, hypernatremia, and may exacerbate hypocalcemia by lowering ionized calcium level. However, systemic pH of less than 7.1 is associated with adverse hemodynamic effect, including decreased myocardial contractility and impaired response to catecholamine preservation. Many clinicians empirically administer bicarbonate to maintain pH more than 7.5. Abnormal salt and water metabolism. Although most fluids administered to patient are hypotonic, plasma osmolality normally remain within the tightly fixed limit. The process by which plasma tonicity is preserved depending on suppression of vasopressin release and movement of the free water in ascending limb of the loop of ventral. This latter function is impeded whenever GFR is reduced and which results in water retention and hypometry. Conversely, some renal disorders are characterized by the failure to conserve water. This situation is referred to as nephrogenic diabetes insipidus, and it is the most common tubular interstitial disease and in partial obstruction of the urinary tract. Patients with this disorder are prone to dehydration and hypernatremia. Now, the abnormal calcium and phosphorus metabolism. The ability of the kidney to excrete phosphorus is normally impaired when GFR falls to approximately one-third of normal. High serum phosphorus level lead to formation of insoluble calcium phosphate salt, which may precipitate in the soft tissue. If the product of serum calcium and phosphorus concentration exceeds, the precipitation in the soft tissue becomes more likely. For this reason, the administration of the calcium to patient with the hyperphosphatemia should be reserved for emergent situations such as appearance of tetany, seizure, and refractory hypotension. In most of these cases, treatment of hyperphosphatemia with the phosphate restriction and phosphate binder improve hypocalcemia. The tendency towards hypocalcemia with AKI may be additionally aggravated by injured kidneys failure to form 125 dihydroxycholecalciferol, although vitamin D therapy is rarely required in cases of AKI. Hyperphosphatemia is common in patients with AKI, particularly in patients with rhabdomyolysis or tumor lysis. Treatment is typically targeted at maintaining phosphate in normal range. Dietary phosphate should be limited to less than 2 grams in patients with AKI. Phosphate binders are typically initiated when phosphate levels rise to more than 5.5 mg per day. The main phosphate binders available include calcium salts, calcium acetate, calcium carbonate, sevelamer, and the lanthanum hydroxide. Unless the patient is hypercalcemic, calcium carbonate can be administered as phosphate binding agent. Although potent, aluminum-based binders are generally avoided because of the concern with aluminum toxicity. Now the next is uremia. Accumulation of endogenous toxin in the body eventually results in uremia. The uremic syndrome is multi-system symptom complex, and the exact identities of the so-called uremic toxin are not known, although many possibilities have been suggested. Urea and creatinine are not uremic toxin, but rather the marker of renal excretory capacity. The serum urea, nitrogen, and creatinine levels do not accurately correlate with the onset of uremia. In general, uremic symptoms develop at GFR of less than 10 ml per minute. Although uremia is considered as an indication to initiate dialytic therapy, the syndrome may be insidious in onset and produce only vague symptoms. Lethargy, anorexia, nausea, malaise, all of which may be herald uremia and may be attributed to extrarenal disease in the patient with AKI. Other less subjective uremic manifestation constitute stronger indication for prompt initiation of dialysis. These include bleeding diathesis, seizure, coma, and appearance of pericardial friction rub. Thank you.